Hi, I'm Patrick Javid, and I'm the chair of the APSA Ethics Committee. Tonight, our group will be presenting difficult cases with ECMO and ethical challenges related to these cases. We've all had difficult situations with ECMO. We've all, whether in our training or in our clinical practice, and this will continue in the future as ECMO becomes more commonplace in our institutions and the indications for ECMO continue to expand. Our first group, led by Elliot Pennington, will discuss a challenging case of whether to cannulate a child onto ECMO. And our second group, led by Dr. Erica Carlisle, will discuss a challenging case of whether to decannulate a child who is already on ECMO. We'll try to incorporate the basic ethical principles in discussion of these cases. And after each case, we'll have a discussion from the entire ethics committee to address some of the questions that these cases bring up. So thank you for joining us tonight, and hope that you can learn a bit from our discussion.
Hi, I'm Bill Middlesworth, and I'm joined today by Elliot Pennington and Sam Rice Townsend. And we're going to discuss a couple clinical scenarios and the ethical principles that might drive some decision-making around how you would care for these patients. Our first scenario involves a 4-year-old female who's undergoing treatment for acute leukemia and is currently admitted to the pediatric ICU at your hospital with pneumonia and acute respiratory failure. She's required rapid escalation of invasive mechanical ventilatory support and is now on high-frequency oscillatory ventilation with an FiO2 of 1 and declining oxygen saturation. The PICU team is consulting you, asking if you would consider ECMO for this patient. Her leukemia has been refractory to standard management and she's not achieved remission, but she was recently started on an experimental treatment, drug X. Based on limited available data, the oncology team feels that her overall survival with drug X is in the region of 1% to 2%. The child's mother is an emergency medicine physician, and her father is a local orthopedic surgeon. The family has read about ECMO and as a potential to treat respiratory failure, and they're interested in doing everything they can to save their child. So Elliot, can I start with you?
Thanks, Bill. Obviously, this is a heartbreaking scenario, but one that we've all been in many times. There are a couple of ethical principles that I think about that this case brings to mind. And the first has for a long time been called futility, although that is perhaps not the best term for it. But futility, or what can now be called inappropriate care, is the idea that is care that is that's not indicated and has a very low likelihood of achieving the desired result. There is no definition, no percentage that is in the literature that defines futility. In the literature, it is defined from 0% up to about 13% likelihood of achieving a desired outcome. I will say we're probably not very good as surgeons of assessing the percent chances of a procedure being successful when the percentages are so low. The difference between a 5% chance of success and a 15% chance of success, I think, would be easy to confuse in this critical situation when timing is of the essence. But in general, I think we would all agree that it is overwhelmingly improbable that the initiation of ECMO is likely to achieve the desired result. But that hinges on the fact that we all agree about what the desired result is. Sometimes just survival is simply surviving to hospital discharge for some families is not what they think of when they think of that desired result. For some families, just getting out of the hospital is all that they want. For some families, getting back to their normal life and the rhythms of their life and what their family dynamic used to be is the desired result. And so it, I think, is critical when we are talking about what used to be called futility and now the American Thoracic Society has recommended to be called inappropriate care, is that we are all on the same page about what the desires are, what the desired outcome of this procedure will be.
Thanks, Elliot. Sam, would you like to comment?
Yeah.
I think this case brings up a number of important and complicated issues, and I agree with Elliot that it is at the same time not unfamiliar. But it's helpful to sort through these issues, I think, with a framework of ethical principles. And one principle that comes to mind for me is this idea of autonomy. And how does the patient, or in this case, the parent's autonomy, play into this decision? And if the chances are slim, but possible, and the parents are adequately informed about the risks and benefit of this therapy, do not the parents in this case have the ability and the right to make a decision for what they feel is best for their child and their family? And I think as a parenthetical point here, I think it's worth mentioning that in the case of ECMO, even when we do not say it or consciously think it, I think we are always weighing kind of these types of rights against what we know to be resource limitations in the real world related to ECMO. But let's say, for the sake of argument, that resources aren't an issue here. This patient is well insured. The hospital has many available circuits and people to run them. And in this case, we have a therapy that has a slim chance of working. But so long as the family understands this and the risks, are we not obligated to respect their autonomy to make a medical decision? And again, in this case, in which it will not affect others, i.e. constrain resources that might benefit someone else, knowing that it could save the life of their child. On the other side of this idea of autonomy, is it really possible for someone who doesn't work in this specific field to have a full understanding of the risks and benefits of this type of therapy, sufficient for us to place the final responsibility of this decision in their hands? And when we speak of an informed consent for a procedure, for example, I really think we're only asking them to have a basic understanding of the risks and benefits of the therapy itself, but do not suppose that they have a full understanding of a situation like this with consideration to long-term consequences of survival, what quality of life might look like in the case of, say, a patient who survives but is neurologically devastated by a stroke on ECMO. So I think, in truth, this makes the idea of applying autonomy thorny for complicated decisions like this.
Thanks. If I could follow up on that a little bit, Sam, you mentioned that you would favor respecting parent autonomy in a situation about whether or not to institute ECMO for this patient, understanding that the chances of the child being saved are very small. Would that autonomy extend to the duration of ECMO treatment, or would you think that there are other considerations involved in potentially discontinuing life support at a point where the medical team felt that survival and recovery was impossible?
I find those situations very difficult. I've been in many of those conversations where people say, well, the chances are slim, but why don't we try for X number of days and then see if we're in a better place, same place, worse place, and make a decision then. I find that in reality, it is extremely difficult to pull the plug once you've committed to the idea of this type of therapy. And so I really would like to avoid that outcome of the decision. However, I think that autonomy is worth honoring if there is ambiguity and if there is conflict in our recommendation. And some people on the team may think that it's worthy of consideration, other people may not. And if there is ambiguity, then I think autonomy may play an important role.
Thanks. Elliot, do you have any thoughts to add to Sam's perspective?
Yeah, Sam, I certainly agree. I think the rights of autonomy and the rights of the parents to make these decisions sometimes butts up against what we know from a medical standpoint, and which is, I think, another important ethical principle of doing no harm. I think we need to consider what will the long-term outcomes be of this therapy. How likely is this patient to live to hospital discharge, to live a life that the family may want for this patient? Will ECMO cause a delay in treatment or a delay in her leukemia? Is it likely to worsen any of her other underlying conditions? And even the concept of autonomy is, while I think critical, is not all encompassing. We're not a restaurant. Patients just don't order off the menu. There are some instances for which we feel that as medical professionals that we sort of know better, right? We don't ask patients what type of suture to use, what their dose of Tylenol should be, how often they should do incentive spirometry. Baked into the physician-patient relationship is some degree of paternalism. And so if we feel that a proposed treatment is not in the best interest of the child or the patient, then and is overwhelmingly improbable to achieve the desired outcome, then we are not obligated to offer that, even if the parents want it. Now, just to be clear, I think informed consent is a critical part of the medical process. And autonomy is extremely important. I'm not arguing otherwise, but if the chances of success are near zero, then I think we need to consider, are we likely to harm this patient with this therapy?
Thanks. And to maybe amplify the point a little bit, what's our responsibility as a lead of a medical team with regard to the moral distress of the people that would be involved in caring for this child? And is that something that factors into our decision in a case like this in the context of parent autonomy?
Absolutely. It's it's not just the surgeons who are part of this team, right? It's the surgical techs and the bedside nurses and the PICU attendings and the entire PICU team, and making sure that everyone is on the same page and comes to, if not an agreement, at least a consensus that we present as the whole treatment team, a unified front, I think is critical.
Thanks. Maybe we'll move on to a little bit of a different scenario where, instead of being highly educated, professional, affluent, native English speaking parents, this same child belongs to a different family, and parents who are recently immigrated from Guatemala, have only been in the United States for about 3 months, and both primarily speak Mayan language, so that getting a translator is challenging, although they have some limited understanding of Spanish. So it's difficult for you to find an interpreter. Eventually, you use a Spanish interpreter, and it's your impression that the family seems to understand most of what's said. The parents work as migrant laborers, either attended high school or has higher education, and they seem clearly overwhelmed by this situation and the context of the ICU and the ventilator and all the machines involved in caring for their child. Among other anxieties and worries, the family is concerned about their ability to pay for her extended hospital stay. Can you tell us how that might change your thinking about this case?
I can respond to that, Bill. First, I think, the contrast between these parents, one who we consider to have, a sophisticated understanding of the medical care being provided, compared with parents who have less education and are from a significantly different cultural background with then language barrier on top of it. It brings to light the concept of equity and how easily we can offer disparate care without intending to. And, in reality, would we truly treat these patients the same, or these parents the same, as the first parents, who are physicians, educated, speak English, are presumably affluent, in terms of their decision-making on these issues? And one could certainly make the argument that we either treat any parent with autonomy, for example, to make decisions in this situation, or we do not. And education levels aside, these parents may have significantly, different values or different value sets, which I think should be recognized and honored equally. And while I would expect that any surgeon would in either case recommend what he or she believes is the right thing for the patient. What if, as Elliot suggests, you do not think ECMO is the right thing for this patient due to do no harm or your sense of futility, and you recommended this, but at the same time, you do not think it is unjustifiable to proceed with ECMO. What if the first parents disagreed and wanted ECMO, while these parents agreed to your recommendation, perhaps out of economic concerns or out of less confident understanding of the situation? And so is that fair? Alternatively, what if the second set of parents disagreed with that recommendation and wanted ECMO, but for different reasons and perhaps less well articulated? And would those reasons be honored equally in practice? And I think it brings to mind our overall approach and whether or not it can be equitable, and are we setting ourselves up to provide disparities in care based on biases or different approaches to these parents who presumably love their child equally.
Those are great points, and I think the case is meant to highlight, at least in one respect, how a parent's perceived agency can color a conversation and can color our response to them. So one set of parents might feel fully entitled to make a medical decision like this, or feel that it was their decision to make. Another family might feel much less assertive, or much less able, or entitled is the wrong word, but that they couldn't justify their opinions as strongly. And I think that that's an important consideration as well. Elliot,
yeah,
think about that.
I fully agree. I think it's critical that we in the healthcare profession are continually examining our implicit bias and making sure that the biases that we all have baked into us, that's why they're called implicit, don't color what we, how we act, in different scenarios. I agree, Bill, that there are some families who feel like it's their right, and they to make these decisions for their child, and they feel very engaged in the process. And there are some families who do not, and feel that they're not, they're really not able to do that. But there are some families for whom that burden of decision is crushing, that they think that if they decide to not proceed with ECMO or with another treatment, that they're killing their child, and that they're so overwhelmed by the process that they really don't want to make those hard decisions, and they turn to us. I'm sure we've all been in that position where a family member says, just do what you think is best. So it's obviously a terrible and very difficult situation.
Yeah, also great points. And I think it highlights how probably when we're really functioning at our best as clinicians, we're able to make those assessments of what a family needs of us in terms of guiding them through very challenging and sometimes impossible decisions like these. And then one last twist on this scenario, that at the same time, one of these two patients is undergoing an analysis of whether ECMO is appropriate, and you're trying to decide whether or not to offer it. A full-term infant with meconium aspiration and respiratory failure presents to your neonatal ICU, and you don't have only one ECMO circuit available, and you can't get another circuit. And so you're faced with a decision of how you're going to allocate this limited resource among two different patients who might both need it, or at least have a perceived need for it. How would you frame a discussion with the family around those? And maybe Sam, will let you take this one.
Sure, and that's a very real scenario that I'm sure we've all encountered. And one would like to think that as a community and as providers that, offer ECMO in a hospital, that we anticipate those shortages and try to make criteria such that you don't end up offering different care to the person who's on the first circuit versus the patient who's getting the last circuit. But these things happen in real life, and I think it's hard to discuss the ethics of decision-making around ECMO, period, without at least mentioning the specter of resource utilization and limitations, even in non-COVID times. And one can always draw on, sort of a utilitarian argument, which is, the greatest good for the greatest number of people. But beyond number of circuits and persons to run them, even when there are 2 circuits, this is a hugely expensive, labor-intensive therapy. And so even beyond number of circuits, do we have an obligation from the perspective of cost burden and limited resources in the real world to offer therapies that we think will be, unsuccessful in the interest of slowing down sort of an inexorable march of increase in healthcare costs that someone must eventually pay for? Or on the other side of that, is it immoral to put a price on a life if we think the therapy is justifiable, if only unlikely to succeed? And so, but I do think even when we're not consciously recognizing it, I think we're so hardwired to think about resource limitation with decisions around ECMO that it's kind of always there, even if we don't talk about it.
Great, thanks. Elliot, would you like to respond to that as well?
Yeah, I agree. This is the battlefield triage argument that anyone who has served in the military or been involved in a mass casualty incident is familiar with. We're extremely lucky here in the US and most parts of the Western world to never really be faced with resource limitations for our day-to-day care. I think that's one of the reasons why thinking about resource limitation feels so bad in the setting of ECMO, but there are lots and lots of places in the world where they struggle with just basic limitations, and these are day-to-day considerations that physicians face all the time. As to having to tell a family, we're not going to put your patient on ECMO because we only have 1 circuit and we're going to give it to someone else is horrible. That, but it is, I think, the choice that I would make to give it to the baby with meconium ileus, and I think probably that's the choice that most surgeons would make if really we're, after struggling tooth and claw to get another circuit and to find a way to do them both. But if you really can't, I think most people would say, as painful as it is, to give it to a baby who has as we know, a 90% chance of survival, rather than this patient who is unknown, but certainly less than 90.
Yeah, I agree. And I think you're right that the coronavirus pandemic really was, for most of us, our first brush with that sort of very resource constrained environment and having to make those very difficult choices. Well, thank you very much both for your discussion. Maybe just to wrap up, I'll ask you each to close. Elliot, if you would, getting back to the first case, the child of 2 physicians, and what would you ultimately do? Would you cannulate the patient or not? And along with your response, maybe you could discuss some of the important points about how you would arrive at that decision with the medical team.
Sure. So I think it's important to sit down with the family and have a long talk about what it is in their family that's important. Is is what things do they like to do? What sort of life do they imagine for their child? But in this situation, I believe that the idea of inappropriate care, or what we used to call futility, is we are really coming up on care that I believe is not indicated or is inappropriate. And along with the idea of doing no harm, and are we going to injure this child by putting them on ECMO, and the likely neurologic consequences that may go along with that. Overall, I would not offer ECMO to this patient right now. Great.
And Sam, same question for you. In the second scenario of an immigrant family who's wrestling with this decision, what would you do in that case? And tell us what considerations you would have in the front of your mind about how you would get the whole team behind your decision so that this wasn't a single person decision, as these things are usually not.
Yeah, I mean, I think that if you have there are a lot of sort of tripwires in this case that I think you have to really carefully navigate to respect the different cultural background that they're coming from. I think trying really hard as best as you can to involve translation services or cultural brokers, maybe family members who can help with the conversation. I think trying to limit those barriers as much as you can is really important. If the family didn't want ECMO, then you're done. If on the other side of that, I would hope that as a provider group, that we would, before even really bringing it to the family, I would hope that we could provide sort of a consensus recommendation. While I agree with Elliot that the chances are slim and the outcome looks pretty dismal, if the oncology team and the ICU team, if everyone else involved felt that this was something that should be offered based on possible outcome that's good, I don't think I would be a standout in that case. In reality, I think I would offer a cannulation as a part of a team that had reached a consensus, even if I didn't personally think that that the procedure was the best idea for the patient. But as a team member in a very complicated decision, I think I would proceed with offering it.
Great. Thank you very much. And thanks to our audience for joining us.
Thanks, Bill. Thanks, Elliot.
Thank you.
Thank you to Dr. Pennington, Dr. Rice-Townsend, and Dr. Middlesworth for our first case today. And now we're going to open it up to a live discussion with our ethics committee. I'm going to throw a question out to the group. We just heard this scenario of a 4-year-old with a malignancy and who has not responded to therapy. The patient's on an experimental therapy. We think the chances are low. And maybe we argue that ECMO is not appropriate here. But I want to ask the group, what do you say if the parents come to you and say, the chances of survival for my daughter are low, but if you don't cannulate my daughter on ECMO, the chances of survival are 0. What's in the best interest of my child is to put her on ECMO. How would you answer that? Because that seems to be a real life scenario at the bedside.
I think you highlight a really important conflict that we face often, and because we have many professional obligations, as many of us are academic pediatric surgeons, so we have an obligation to teach and educate. We have an obligation to the family, which I think often probably takes the highest priority for most of us. And we have an obligation to be responsible stewards of healthcare so that we can afford to sustain a high level of providing excellent healthcare. And what you describe is a family saying what they want for themselves, and it might be in conflict with what's best for everyone or the greater good. And so I don't know that there's a great answer for that, other than to sort of gently hint at the idea that resources are not infinite. I think it's hard to say, well, we have another candidate who's better, so we're not going to apply this technology to your child. I think it's a little more palatable to say that I'm sorry, but we don't think that's a responsible use of the resources that we have. And we're really obliged to do the best we can for everyone and to approach the discussion in that way. But be interested in what others have to say about that.
I appreciated in the conversation, Sam had mentioned that autonomy is so important. However, he mentioned the concept of ambiguity being an important condition where autonomy would kind of trump perhaps provider recommendations. So in this situation, I think it's important to think through if it is an ambiguous outcome, it might not be a high chance of success, but there might be some ambiguity, and that would perhaps permit some parental autonomy. In contrast, if there really is very little ambiguity and the medical providers understand that this is a lethal process, then simply submitting to a parental wish, as difficult as that is for that family, would certainly not be in that child or ultimately that family's best interest. So I think autonomy cushioned in a setting of ambiguity makes a lot of sense, and I appreciated Dr. Rice-Townsend mentioning that.
Your scenario brought up two scenarios of two families. So there was the 4-year-old with parents who were both physicians and lived in the United States and spoke English. And then there was the 4-year-old with parents who may not have had advanced education, did not speak English, and had just moved from Central America. It seemed that one family was able to better advocate for their child than the other family. And it was that strong advocacy that maybe led to the ethical questions. And so what I'm wondering is, in this situation, how do we balance the principles of autonomy, where the parents have a say in the decision, but also the principles of justice and equity, where we want to treat children equally and have equal outcomes?
So I think for me, one of the challenges with that is trying to remember who it is that I'm taking care of. My obligation is ultimately to the patient. And you may argue that a patient exists within the confines of his or her family. But ultimately, the task is to make decisions that are consistent with the best interest of the patient. So especially when I have concerns about my own implicit bias weighing into my decision-making, where you have families with very different resources and different abilities to advocate for their children, as we saw in this case, I try to ground myself by reflecting on what it is that I'm actually doing. And if I don't feel like the request is within the best interest of the child, I try not to let those factors weigh into my decision.
Yeah, I mean, to respond to that a little bit, Patrick, I think it's, none of us want to offer disparate care to two different patients who would, theoretically be in the same position medically, because of, one set of parents or pair parents advocating for their child and another not, and that being sort of the deciding issue. So I think, in one sense, it kind of limits the amount of role that autonomy can have if we're really going to, try to limit the opportunity for discrepant care between these two patients. I think we have to really focus on, as Erica was saying, focus on what we truly believe is best for the patient and try to make a sound recommendation and feel like we would make that same recommendation to any parents in either situation. Now, I think if you made a recommendation to go on ECMO, on the other hand, and parents didn't want to do that for different, set of cultural values, I think that's sort of a different scenario, and you would have to be careful about honoring what might be a very different belief set than yours.
I want to make a little plug here, just in all of these scenarios. I think, Sam, that's a really, really good point, and actually a good starting point for a conversation about cultural differences. And I feel like it's really important, especially like you have the best interest of the patient in mind, of course, but then also trying to find out where like the cultural beliefs and the viewpoints of the family, like what do they want? What are their goals? If they, do they, like, you have to, ask about like suffering and, all of the things you kind of have to figure out, like, what are the values and the cultural bases that the family starts, where does that family start from? And then I think from there, and because I think that plays into the best interests of the child. And it's, I think, the responsibility of the provider to, find somebody who speaks the appropriate language and to communicate these things and to find out, kind of dig a little bit into the family to figure out all of those things before making a recommendation. And that's hard to do when you have very little time to make a decision. And I don't know if that actually ends up, bringing in our biases more or less. But I think if we can at least find sort of a starting point from a belief system standpoint and what values the family has, that is ultimately in the best interests of the patient. And the problem is, like, sometimes it's not. Sometimes it's exactly opposite. What you think is the right thing for the patient, and what the family thinks is the right thing for the patient.
I'd like to follow up with a question. In the end, Sam said for the 4-year-old with cancer, if all the teams agree that it was worth giving the patient a shot, then maybe you'd go ahead and cannulate. I wanted to bring up something that our committee has focused on a lot this year, and that's moral distress for the provider in this situation, because we've all been in situations where, members of the entire team feel that it's appropriate, but the surgical team may still think it's potentially inappropriate care. How would you address moral distress for the provider in this situation where you may feel that the best interests are in one direction, but the entire team is moving to another direction of care?
If I may chime in a little bit, I think we really need to identify goals of care in this kind of situation. And if we have a child with refractory cancer that we don't have a long-term treatment plan for, then what is the purpose of ECMO? It's not really a bridge to another type of treatment. It's a wishful thinking, and that is never a plan or a goal. So I think those kinds of ideas need to be clarified and discussed. And I think engagement of the palliative care team early on in the decisions either to go on or not go on ECMO can be very helpful in navigating the team through these difficult situations.
Yeah, I think that makes great points. I think in any situation like that where individual might find themselves at odds with what seems to be an evolving majority opinion, you would sort of wonder why. And backing up to what you agree on is sometimes a useful strategy. So it might be that there's an element or a conclusion that's based on different assumptions by one group than the other. And so I think backing up a little bit to clarify the goals, the likelihood of achieving those goals, and just sharing, that starting point is sometimes helpful in arriving at a better consensus.
So we're excited to present a case that highlights some of the ethical challenges associated with decisions regarding decannulation during the seemingly unsuccessful ECMO run. To facilitate focus on the ethical questions and limit possible distraction by medical specifics, we've purposely designed the case in which we offer a little medical detail. But I think it's a case filled with ethical challenges that many of us can relate to. And I look forward to your comments and discussion regarding these issues. So a 4-year-old was admitted with sudden cardiorespiratory failure of unknown etiology, and ECMO was initiated. Extensive workup has not identified an exact etiology, and the child has now been on ECMO for 28 days with no significant improvement. Prognosis is poor, and the healthcare team is discussing decannulation. There are variable attitudes among providers regarding the appropriateness of decannulation. The PICU team prefers to continue ECMO for at least another 7 days, and the surgery team thinks it's most appropriate to decannulate today. The parents continue to request that the team does everything. Our discussion will be guided by a review of 4 ethical issues highlighted as we consider this case. Dr. Leguh-McKee will discuss the overall goals of ECMO. Dr. Jason Sokowski will discuss the ethical equivalence of withholding and withdrawing care, even though they feel different. Dr. Badr Shakshir will discuss the futility or potentially inappropriate care, as well as the transition from long shot to fantasy care. And Dr. Ryan Antiel will discuss the issues of cost and resource allocation. Welcome, Dr. Akai.
Thank you. Hello and welcome. In general, ECMO is initiated in children for 4 overarching reasons: bridge to recovery, bridge to decision, bridge to organ transplantation, or bridge to a bridge. Specifically, ECMO is used as a bridge to recovery for known treatable and potentially curable diseases. It can also be used as a bridge to decision, which provides time for recovery, diagnosis, clarification of prognosis, or determination of candidacy for alternate mechanical support or organ replacement. When using ECMO as a bridge to a bridge, it allows for stabilization and transition to a longer-term assist device or a bridge to organ transplantation. In this particular case, ECMO was initiated as a bridge to decision. This otherwise healthy 4-year-old child presented with acute cardiopulmonary arrest of unclear etiology, and ECMO offered the clinicians time for investigation, diagnosis, or prognostic data gathering to determine potential for recovery or organ replacement candidacy. When initiating ECMO, being clear on this purpose can help providers and families better understand and accept the threshold for stopping a course that is unsuccessful in accomplishing this intended goal. This intended goal is also important to improving informed consent. Informed consent in this urgent setting is challenging, and overall understanding by families is often limited. To mitigate these challenges, it is imperative that ongoing communications about risks, benefits, and potential for failure occur early, openly, and repeatedly through the ECMO course. Reassessment of the balance of benefits and burdens, identification of key markers indicating progress or worsening, and emphasis on the temporary nature of the support can help families and caretakers understand how to interpret success or lack of progress. Although conversations about the potential need to stop ECMO if the broad purpose cannot be met need to take place early and repeatedly throughout the clinical course, true consent for decannulation cannot be achieved prior to cannulation. In that case, consent would be made under duress, and the understanding that the potentially life-saving technology would be otherwise withheld can be deemed coercive. Should stopping a seemingly unsuccessful course of ECMO be met with disagreement by families, the withdrawal of such a previously signed consent for decannulation is not only permissible, but also likely. In addition, prior consent would not supersede the need for extensive communication, mediation, and support for both the family and the medical team. As a result, overall, conflicts about stopping an unsuccessful course of ECMO are best avoided by clear communication throughout the course about goals of ECMO and whether the goals are being met. Thank you.
Thank you, Dr. Akai. We'll now turn to Dr. Sulkowski.
In this case, a patient has been on ECMO for an extended period of time, and the discussion now centers on whether it is appropriate to withdraw treatment. As many of us have experienced, this discussion often feels very different from the initial one that is held to decide whether to proceed with or withhold treatment. A survey conducted in Sweden showed that only 37% of physicians felt there was no difference between withholding and withdrawing treatment. And a separate study in several other European countries showed that only 1 in 3 physicians agreed with the statement. From an ethical point of view, there is no difference between withholding and withdrawing intensive care. Many ethicists take the position that there is no ethical difference between withholding and withdrawing care. This is known as the equivalence theory, with the caveat that all other factors are equal. Similarly, guidelines put out by numerous professional associations regarding end-of-life discussions suggest that there is no ethical or legal difference between the two. If this is true and there is no ethical difference between withholding and withdrawing care, why does it, for many of us, feel harder to remove treatment, like an ECMO circuit or a ventilator, than it does to not start the same treatment? One reason is that withholding care is viewed as an omission or inaction, while withdrawing care is an action. If ECMO is withheld, our omission of treatment allows the natural course of events to play out, but we did not do anything. For the cannulated patient, it seems that without the act of decannulating them, they will continue to survive. In reality, the decision on how to act is made in both circumstances. In one, our action involves continuing the same course of care without the addition of a new treatment. And in the other, the action involves transitioning the patient's care in a new direction or withdrawal. Since both withholding and withdrawal are actions, and the outcome in this context is the death of the patient, it is important to view both as letting the patient die rather than doing something that causes their death. The patient is under our care because of a terminal illness that we are keeping at bay each moment with our interventions such as ECMO. By removing the circuit, we are not killing the patient, but allowing them to succumb to their illness, which also would have happened if ECMO was withheld at the outset. Another reason for why the two seem different in practice is that as physicians, we take responsibility for patients when we begin to treat them. We feel a professional and moral responsibility to not only the patient, but their family as well. This raises our subjective moral threshold for withdrawing care. However, our goal as physicians should be to obtain the best possible outcome for each patient. If the best outcome does not involve heroic measures, it should make no difference if that determination is being made before or while such measures are provided. Ongoing treatment can be viewed as conditional, with each moment being a new opportunity to decide whether to continue or withhold. Based on this view, withdrawing care is not any different from postponing withholding. There are risks in not acknowledging the equivalence theory. Physicians may be hesitant to start treatments. They may fear it might be difficult to withdraw later, or that some unnecessary treatments may continue for longer than necessary, potentially causing harm and delaying the inevitable. It is important to point out that the equivalence theory is based on the assumption that all things are equal between the two circumstances for withholding and withdrawal. If the patient was placed on ECMO and demonstrated marked improvement, it would not any longer be considered ethically justifiable to withdraw treatment. This is another component in why it might feel different to withdraw, is that a patient's course is never entirely linear, but characterized by ups and downs. How can you really say that the patient you first saw in distress prior to ECMO is the same one now after 4 or more weeks on the circuit? Decisions to withhold or withdraw care are always difficult. The ethical concept of equivalence between withholding and withdrawal should be seen as implying ethical permission, but not necessarily justification, as every situation will be unique. To quote a recent article in the American Journal of Bioethics by Rosamond Rhodes, the factors that are morally telling include knowledge, wherewithal, responsibility, and the details of the situation. And in every choice, people should do the right thing.
Thank you, Dr. Slokowski. And before we transition to the other two discussants, I'd like to add a twist to the case. We've now been updated that the child has suffered a precipitous drop in hemoglobin and sudden abdominal distension. Ultrasound demonstrates a large volume of free fluid in the abdomen that's consistent with blood, and there's discussion of the need for an urgent exploratory laparotomy. Welcome, Dr. Shakshir.
When it comes to cases like this, we approach the case seeking a means by which to help our patient. Weiss and Feister discuss cases such as this in their paper in the 2018 American Journal of Bioethics. They describe even further pressure may be present at referral centers where helping more complex patients is seen as part of the mission. However, one must understand the transition in situation from long shot to fantasy. The authors argue that the term fantasy is separate from the terms futile and inappropriate care. They provide a scaffold by which to view and understand the transition from long shot treatment to fantasy treatment. This scaffold is provided in 4 stages. In the first stage, the family is approached about a treatment that is unlikely to work, but still has the potential for benefit. In the second stage, the long shot treatment is initiated despite the risks because of the potential benefit. The third stage is the one that causes the most ethical discord. In this case, we look to be in stage 3. We have approached a long shot treatment and have suffered a significant complication. We are in the midst of the murky waters. Members of the treatment team start to feel that the original goals that were set, though originally felt to be unlikely, are no longer achievable. The odds of success move towards 0. Whereas there may be disagreement about the exact location of impossible, everyone agrees that the odds are diminishing. The authors write about stage 4, where there's universal clinical agreement that the patient's treatment plan is crossed into pure fantasy. In some cases, stage 4 may never be reached with universal accord. To correlate with these stages, they structure a framework of communication for situations such as this with long shot therapy options. Most critical from their framework is that communication take place in a regular and open format with the family. When the situation reaches stage 3, that is the murky waters, where the members of the treatment team feel that the odds of success are diminishing and approaching 0, it is important to describe this clinical picture accurately to the family. In an ideal scenario, this conversation has been framed earlier during stage 1 and stage 2. The authors argue that the term fantasy is preferred to futile. The term fantasy is colloquial and more easily understood as a non-medical concept. It appropriately demonstrates that the goal of a cure is wishful thinking, no longer real, but make-believe. There is precedence for many of our supporting societies about futile care. In 2015, a joint policy statement was published by the American Thoracic Society, American Association for Critical Care Nurses, American College of Chest Physicians, European Society for Intensive Care Medicine, and Society for Critical Care. This document argues to utilize the term potentially inappropriate rather than futile in cases such as this. They argue that using the term inappropriate conveys a judgment based on medical expertise rather than a value-laden claim such as futile or ineffective. Further, the term potentially states that this is a preliminary rather than a final judgment. In this policy statement, they advocate that the clinician should not feel obliged to provide potentially inappropriate care. It sets out a process by which conflict resolution can take place if the physician and the family are in discord. Further, they advocate that the term futile should be restricted to the rare situation that interventions cannot accomplish an intended physiologic goal.
Thank you, Dr. Shakshir, and welcome, Dr. Antiel.
Let's turn our attention now to issues of cost and resource allocation. In 2019, the percentage of our gross national product going into healthcare was about 17%, or approximately $3.8 trillion. We spend approximately $26 billion a year on neonatal intensive care. In a 2016 paper in the Journal of Pediatrics, which examined the hospital costs for pediatric ECMO survivors, the investigators reported that for 99 neonates with CDH that year, the total cost was $42 million. And of the 54 of the 99 that survived to discharge, the cost per survivor was approximately $800,000. Healthcare is expensive. Neonatal intensive care is expensive. ECMO is expensive. The first question I want to examine is, should neonatal intensive care be rationed? Should ECMO be rationed? Or should we prioritize funds for other important priorities, such as childhood vaccination programs, funding for children with disabilities? In order to answer this question, there's a few premises that I'm taking for granted. First, there are unlimited healthcare needs. Second, there are limited healthcare resources. Third, we always have rationed healthcare and will always ration healthcare. The question is how we ration, and this is driven by competing priorities. In 2009, I published survey data on healthcare reform and cost effectiveness in the New England Journal of Medicine, which demonstrated that 67% of US physicians favored limiting reimbursement for expensive procedures if that would help expand access to basic healthcare for those currently lacking such care. So the cost of ECMO, I believe, should be factored into decisions about whether to provide it. It's not the only factor, and it's not the most important factor, but it should be a factor. Which leads us to the second question. Which neonates then are too expensive to treat? Oftentimes when attempts to determine this are really based on benefit burden calculus. It's uncontroversial that those who stand no chance to benefit should not be treated. It becomes more gray when we're trying to determine how a limited benefit to the child may or may not be outweighed by the burdens of such treatment for that child, and for others, the family, siblings, parents. Possible solutions to this calculus have been proposed by a real diverse range of ethicists, Some of those solutions include 1, a trial of treatment for a defined time period, or 2, an explicit prognostic threshold for treatment exclusion based on some existing consensus. And we're already used to using these sort of threshold for treatments in the neonatal intensive care unit, for example, over resuscitation of premature infants. The final question to examine is, should physicians be the gatekeepers of this rationing? The late physician and philosopher, Dr. Edmund Pellegrino, wrote, quote, "This role is morally dubious because it generates a conflict between the responsibilities of the physician as a primary advocate of the patient and as guardian of society's resources. The integrity of the physician's primary responsibility to her patient is something that society must preserve," unquote. Thus, I too argue that it ought to be hospital committees, healthcare systems, national organizations that are the ones creating and implementing policies, not simply leaving it up to an individual physician at the bedside to be the determinant of the rationing. Thank you.
Thank you to our speakers. You've provided a rich discussion of some of the ethical issues surrounding this case, and I look forward to opening the discussion to questions submitted by the audience. Thanks.
Thank you, Drs. Carlisle, Akai, Shakshir, Salkowski, and Antil for presenting that case. I have a question about sort of a worst case scenario, and this takes that scaffold of long shot to fantasy maybe to a stage 5 even, where now the provider team is on board with decannulation, let's say, but the parents are against decannulation. How would you address this? How would you handle this situation where there's a difference of opinion between parents and the medical team for basically redirecting care?
So I think your question is great. You bring up the idea of unilateral decannulation of ECMO. And there's a fair bit written about this in the ethics literature in terms of different arguments. Some will say that ECMO is a procedure or an intervention that at some point becomes inappropriate to continue, and then it ought not be continued. So there's not need to get consent for decannulation. The counter to that is that decannulation is a procedure associated with risks and warrants consent. So it does need consent. So I think there's really varied opinions on how to navigate those two discrepant opinions. And I think ultimately, practically, we continue to work with families until we can usually get them on the same page as us and sort of set time-limited trials in terms of what we'll look for to demonstrate success or failure, or sort of concrete reasons to move forward with decannulation when we really don't think it's appropriate to continue with ECMO. But I think the concept of unilateral decannulation is very, very interesting to debate.
I was going to weigh in a similar way that even just heparinization carries risk associated with it. And so every treatment is a balance between benefit and risk. And if you've sort of run out of benefit and all you have for an invasive therapy is risk, that in itself is a form of harm, right? That you're jeopardizing somebody's health further. And, it sounds a little disingenuous maybe because, taking off or taking away the life-sustaining or at least circulatory sustaining ECMO is going to result in the child's death. But it's a great question and a tough one. I think approaching it with kindness and trying to always never have the family think that you're on an opposite side than they are, and reassuring them that you want the best thing for their child just as they do can help in sort of forming that alliance that you need to come to agreement.
So I wanted to ask the group about rationing. We heard a lot about that at the end of this case, and rationing is a way to achieve equity and justice so that limited resources are distributed fairly and evenly. But there's also the ethical concept of autonomy, where a patient or their family has some say in the direction of care. And in rationing, the decision is maybe made away from the patient's bedside. So I wanted to ask the group how we can balance the concept of rationing leading to justice or equity with the concept of autonomy to allow the patient or their family, in this case, some say in the direction of care.
You raise a lot of important points, Patrick. I think one of the points you're emphasizing is that larger societal questions about rationing, how we distribute funds, whether that's funding for education, funding for welfare services, funding for healthcare. It's kind of a larger societal question, very complicated, that, as you mentioned, takes place away from the bedside, and perhaps even more pertinent to our daily practice would be policies that our intensive care units or our hospital committees make, putting boundaries over the type of care that we provide. Again, a pertinent example would be many neonatal intensive care units have very strict policies about resuscitation of premature infants. And although different hospitals may vary, a lot of hospitals will say, be it 21 weeks or 22 weeks or 23 weeks, those providers will not offer resuscitation in those instances. Other hospitals have more ambiguity or grayness over those policies. So those are things that, again, are taking place after a lot of discussion with multiple parties weighing in. Those are things that aren't taking place, obviously, at the bedside. Where patient autonomy comes in, I think, is kind of within those boundaries, perhaps. So within the agreed upon distribution, whether it's at a national level, a state level, whether it's particular hospital policy, those provide some boundaries that we as providers can work with the families and offer them some autonomy over some of those choices. Obviously, we are limited, our healthcare system's limited, our nation has limitations, and so these families don't have endless opportunity, but we can partner with them, make them feel empowered to make some of those decisions within these boundaries that have been set up to hopefully offer a more equitable system for all children.
I was also going to just briefly add that there's an area where autonomy or someone's own independent actions and ability to carry them out influences other people and other things, right? And so where my independence might affect someone else or constrain someone else's rights or abilities or maybe resources that they have access to, that might be the hard stop for autonomy, that we can't say someone's actions or their feelings don't affect anything else, because they do. And so it's, in some ways, autonomy is a little bit of a flawed concept. And I think you could argue any action anybody takes affects more people than themselves. It's interesting how there are such strong cultural differences. I think that having worked a little bit in other healthcare systems in other countries, I think that people from the United States have a much stronger developed sense of autonomy and a right to autonomy. People from other countries maybe take it for granted that resources have to be shared, resources have to be allocated, and there has to be a consideration for what goes to the greater good rather than just themselves. And I think that that's really interesting cultural differences along those lines.
I'm glad you brought up that difference, because I think as a country, maybe as a world, but definitely as a nation, we're struggling with the autonomy related to vaccination right now. I'd like to ask a question to the group about equivalence theory. And Jason brought this up in his talk about withholding versus withdrawing care and the ethics of both actions. And in a way, our entire session today is framed around that. Our first case of potentially withholding care and our second case of potentially withdrawing care. And the equivalence theory states that there's no ethical difference if it's in the best interest of the patient between withholding and withdrawing care. But as I thought about that more, I thought about the concept of non-maleficence, do no harm, that is ingrained in all of us as physicians and as providers. And I wanted to ask the group, how does withdrawing care not violate the concept of non-maleficence if you know that withdrawing care is going to redirect and potentially lead to an adverse outcome?
I think, Patrick, you have to think of suffering of the patient in those situations, and that withdrawing care might be actually the kind thing to do for the patient and stop the accumulation of suffering. So that's how I would reconcile those two concepts.
I think it's also important to, in either aspect, as Deborah brought up, the role of palliative care, because we are an action-oriented service, whether we're withholding or withdrawing care, and to provide the family with the idea that they're not being abandoned in this decision-making process, and we're providing another resource to them as palliative care is very important.
And when would people get palliative care involved here? I mean, it sounds like there are multiple opportunities to do so.
I think the prospect that you might not be able to offer a curative treatment is there from the start. So I would have regular meeting with the parents and also involve palliative care from the beginning.
I would argue that palliative care should be involved in every ECMO patient, not just because, many of them will have a positive outcome and will recover and the ECMO run will be considered successful. But I think that those patients are so critically ill that palliative care is so often helpful in clarifying medical decisions, even of a more minor nature, and just, maybe bring a team together. They're sometimes the sort of hub of the wheel that makes specialists come together and talk through treatment options in a really constructive way.
I agree with Bill. I think palliative care should be involved at the very beginning because they have a skill set that they've developed that in a way of interacting with families and being a more objective observer as a liaison between the various factions that are caring for the baby, whether it's the intensivist or the surgeon, and their ability to communicate maybe more effectively than we can.
And they also provide support for the team, which may be experiencing a great deal of moral distress under these circumstances. So I think their role is very important and can be very beneficial to all the parties. And they're not they're more of an impartial party in this situation.
Well, I wanted to thank everyone for tuning in to our session tonight, and I wanted to thank everyone on their ethics committee for their work and participation in this project.